Welcome to the Samaritans Purse International Health Forum. Thank you for joining us. We hope that you all participate in our conversation today. You can chat with us in the chat box beside the video. Before we begin, let's begin with prayer. Father God, we are thankful for your sovereignty, for your grace and love. We thank you that there is no person on this earth that you forget about. And we are aware of that because of the people that have left Myanmar and are now seeking refuge across the border in Bangladesh. The Rohingya people are in many ways an unwanted, unloved, stateless group of people. And Father, we thank you that Samaritan's Purse has had an opportunity to serve them. We look forward to hearing what we learned today. Thank you for this opportunity. In Jesus' name, amen. Dr. Andrew Doyle is a pediatrician currently living and working in the Atlanta area. Through 20 years in the Army, he has experience with practicing medicine in austere and insecure locations. He recently served with Samaritan's Purse as part of our response to the Rohingya refugee crisis in Bangladesh. Today, Dr. Doyle will present Diphtheria in a Refugee Setting, Bangladesh 2018.
Okay, well, hello everybody. And good morning, good evening, good whatever time it is, where you are, and whenever you happen to watch this. So a few disclaimers before we get started. This talk is going to be primarily from my own experience of what was going on in Bangladesh while I was there. The response has obviously gone on much longer than I was there, and there are people out there who were there, who've been there more than I have possibly, who may even still be there when they see this. But I'm going to talk about my perspective and from what and what I knew, and we'll talk a little bit about diphtheria in general, and because many people in the West who haven't gotten the opportunity to go to Bangladesh and experience this will not have ever seen diphtheria. So it's a very dry title. I wanted to come up with something more exciting and fun, but didn't seem appropriate. So anyway, we will go to the next slide and get started. We're going to use this case to kind of frame our discussion today. This is a 4-year-old male who was brought into the clinic, or actually was brought into the clinic, by an ambulance from the nearby MSF clinic, the Doctors Without Borders clinic. I won't say the French name because I can't pronounce French very well. He was brought in because he had a severe respiratory distress and possibly some stridor going on, had an oxygen requirement, and they tried to treat him in their clinic with normal things such as oxygen, albuterol, and epinephrine, and it didn't work. So they brought him to our clinic over at where we were treating for diphtheria. And the question that you face, obviously, when you run into this is, what is it, and what are we going to do about it? And we're just going to tease it with that, and we'll move on to the next slide. The very dry objective slides that all CME qualifying talks must have. So what we're going to talk about today, as I talked about, was the presentation and pathology of diphtheria, the treatment options, especially diphtheria antitoxin, and other things you can do. And then we're going to try and put this in the context of the refugee setting and all of the things that go on that you need to think about, at least from my experience of understanding how going through it, that go on within the context of trying to practice medicine and help people in this sort of setting. And there's a whole bunch of P words there. I won't go over them, but they may be important to you if you try to do the CME quiz. So knock out the first of it, the politics. So everything is political, especially in this setting. A refugee crisis, by definition, is a political event. So it is, or better said, it's really the consequence of a breakdown of effective politics wherever you are. So, so when you're in this setting, you have to bear in mind that there are multiple power players and political interests, both from the external and internal players, those that are within the refugee camp itself, those in the host nation, those in the nations from where they came, potentially the refugees themselves, and all of the people that have shown up with at least the outward agenda of trying to help, because we're all just here to help. And everybody has an agenda, everybody has a goal. Even us, as we went there, had an agenda and a goal, which may or may not be in concert or conflict with everybody else's agendas and goals, but we're all trying to do the same thing and ultimately help and solve this problem. So you just have to be aware when you walk into this sort of setting that there are multiple agendas, said or unsaid. You have to work it out through partnership, and hopefully through partnership with others to get help to the people when they need it. So just remember, things are political. So we'll move on to the next slide. So in this case, as was kind of mentioned, and many know, there's lots of people around that suffer. So in this case, there are multiple people there. You have to think about the people. I'm sorry, I just got confused on my slides there. So you have to think about where they come from. So they're refugees. They're not from home. They're not in their home. They're in a new home. So what were the conditions they came from, and where are they now? What have they gone through? Because again, they're refugees for a reason. Something has driven them away from where they are, which could be very traumatic or not as traumatic, but there's some level of trauma. And how is that going to impact the care we provide and what they perceive? And really, when you get down to it, we may be taking care of their medical issues, which is what we'll talk about in this case. But you always have to think about, what are their real needs? What do they truly need? How far can you go with things? And we will get to that later, but those are just kind of the general context. So the next slide, please. So as many of you know out there, that this all started way back a year ago, almost a year ago today, back in August, September of 2007. You have the Rohingya people group, which were a minority persecuted people group living in the coastal areas of Myanmar in what you see on this map as the Rakhine state. Don't know if I pronounced that right, but for years they have been a persecuted people group within Myanmar, which we'll get to in a little bit more in a second. And I don't remember exactly when it was, but sometime around last August, there was an attack by a Rohingya group against a government facility, which triggered the Myanmar government to retaliate and to respond. The response became violent. I'm not going to get into the details of it because it's disputed and it's not really important so much, except to know that they were persecuted and driven. And the result was that upwards of the slightly over 1 million people living within that people group fled Myanmar over the course of the next 1 or 2 months. And the easiest places, you can tell by the map, for them to go was to cross the border into Bangladesh. And last count that I saw, and it could be different, was upwards of 800,000 of them moved from that very large red area to that very small yellow area in the southern end of Bangladesh. So moving on to the next slide, we can talk more about the Rohingya people group to just give us. So again, as I said, 800,000 settle in southern Bangladesh. They are a 100% Muslim group. They are one of the most unreached people groups out there in terms of Christian mission. They have long been oppressed in Myanmar, which kind of led to the events that occurred. And part of their oppression, which is important to what we're going to talk about, is they had little to no access to health care and no vaccines. And again, this persecution led them to flee their home country. So moving to the next slide. So they show up in Bangladesh. And the area in Bangladesh where they went was at one point a forested national park area. But you can see these are pictures of the camp where they are now living at this time when I was taking the pictures, which was last January. And you can see there's not a lot of trees. We're going to see more, but you can see the shelters that they have. And there's more than 1 or 2 or 3 people living in those shelters. And you can see by people standing and the fan there, the size of these shelters. So they're pretty crowded. They're in a very tight space. They're living in very rudimentary shelters that are overcrowded. Next slide are more pictures of what things look like. So that hillside at one point was probably heavily forested, but it is no longer on all of these hillsides because people needed wood to make their shelters and build fires and cook and do all those things. So But for our purposes and what we're going to talk about, the main issue is that they are living in a very densely packed area right on top of each other, which is going to become very ripe for disease progression. And so that's exactly what happened to them. So in Bangladesh, then in November, so they fled really in September, October. They get settled or start to settle in Bangladesh. And then by the middle of November, they start to see some cases of an upper respiratory disease, which is quickly diagnosed and recognized to be diphtheria. And diphtheria is a highly contagious disease, which we all know about, and we all don't have this in the West anymore because we take vaccines for them. It primarily occurs in the winter months, so we were getting into winter at this time because it is the northern hemisphere. And it spreads like wildfire within a highly compact, non-immunized population, which is what we're looking at. And you can kind of see the graph there on the right. The opening cases there are kind of the mid-November. It starts showing up, and by mid-December, you can't really tell it in there because those are how it's written for the weeks. But you can see the cases, suspected and probable cases, shoot up very high. And then those are the numbers on the left there of January 2018. By the end of, we're 5,000 confirmed probable suspected cases, 36 known deaths. And those are, so of course, those are deaths that were reported and to the authorities. Who knows how many deaths were not reported? And of known cases, you see a 70 over 10,000 attack rate. So it was moving pretty quickly through the population at that time, and those on the ground that were taking care of the refugees started to act and move as quickly as they could. And that's also then what triggered Samaritans Purse to show up, as the World Health Organization, which was on the ground, and MSF, which were on the ground, started looking for help. The World Health Organization came to Samaritans Purse and asked if we could help as well. And so we did. So let's talk a little bit about diphtheria itself, going to the next slide. So I found it interesting to go through the history of it because as a medical doctor in the West, my knowledge of diphtheria for the most part, and even as a pediatrician, was it's really bad, and it causes this thing in your throat called a pseudomembrane that nobody had ever seen in my training. And we vaccinate for it, and it's really good to have the vaccine. So I decided to look it up. It's one of the oldest recognized diseases out there. So our good friend Hippocrates, or as I like to refer to him based off of my cultural upbringing of Hippocrates, describes it in the 5th century before the Common Era. And then later in the 6th century, epidemics occurred, also described by a Greek guy. Moving through, and then it's just kind of hanging around out there because we didn't know what to do with it until 1826. We finally gave it a real name. So then this French guy, Bretonneau, names it Diphtheria, because taking from the Greek diphtheria, meaning leather. So because of the leathery consistency of that pseudomembrane that forms in the back of the throat. So okay, so now we have an agreed upon name for what's going on. We still don't know what causes it until 1883, when Klebs and Lothair both discover it independently and describe it. So we can't decide who actually describes it first, so we give the name to both of them of the Klebs-Lothair bacterium. So now we know what causes it. We still don't know what to do about it until 1898. Emil von Behring develops the antitoxin to treat diphtheria. So he develops it from horse serum, from growing diphtheria and pulling out the antigens from a horse, which is such a great thing that in 1901 he is awarded the Nobel Prize. And I'm going to read from his citation. It says, for his work on serum therapy, especially in application against diphtheria, by which he has opened a new road in the domain of medical science and thereby placed in the hands of a physician a victorious weapon against illness and deaths. So that sounds pretty cool. So he gets that. And then moving forward, we start to develop vaccines. We finally developed the toxoid vaccine in the 1920s, and now we can prevent it and start spreading out. The one other thing that I found very kind of interesting, because I like medical history, is 1925 is the great serum run to Nome, Alaska. So on the way out in Nome, Alaska, it's the winter, and a couple kids come down with what looks like diphtheria. And so there's one physician up there who starts recognizing this, and he starts trying to treat. However, he doesn't have a whole lot of antitoxin, and diphtheria is now starting to run throughout the population, and he is justifiably terrified that he's going to have a great epidemic and lots of deaths on his hands. The problem, of course, is that he's in Nome, Alaska, and it's the winter, and nobody can get to him. So everyone is mobilized, and they decide to deliver. They can't first think about doing it by various methods, and they come down to they have to deliver antitoxin to him by sled dog. So from Anchorage to Nome, which is a sled dog relay and race goes through to get the serum, the antitoxin, up to them in Nome, Alaska. And if you know the route, that is the same general route as the Iditarod, which some people claim it came about in recognition and remembrance of this serum run. And the other interesting thing, especially from a pediatrician perspective and loving Disney movies, is if you know Balto, the sled dog, he was the lead sled dog on the final run that went into Nome with the serum, and they were able to stave off this epidemic. So that's just kind of cool stuff if you're a pediatrician. So moving on to the next slide, back to the boring science. So diphtheria, what causes it? We can look this. Now it has an official name of Corynebacterium diphtheriae. It's an aerobic gram-positive bacillus, which is going to help us figure out which antibiotics to use. Of course, there you can see the various biotypes. Now, the tricky part comes down to is that all diphtherioids are normal colonizers within our mouths, because our mouths are yucky places. And then you get a bacteriophage that infects the diphtherioids, and it causes the toxin, and now we have a toxic disease. So it's interesting. So talking to some experts when we were in Bangladesh, one theory actually is that that's how these epidemics start, is we're all colonized with regular non-pathogenic diphtherioids. Something happens to cause the mutation in the bacteriophage, and then they pop up, because these epidemics tend to happen in isolated events, not spreading from one population to another one. They just happen. So if you aren't immunized against the bacteriophages and the diphtherioids that are going to be attacked, then that's what happens and how you get the disease. So moving on, I think talking some more about diphtheria, because we have to get through the boring clinical stuff, is diphtheria, the clinical feature. So it grows pretty quickly. So it takes only a few days from being exposed through incubation. So 10 to 5 days, range is normal 1 to 10. And if you were able to look more closely at that graph earlier, you can see the initial cases are scattered 1 or 2. And then within about 1 to 2 weeks, all of a sudden the cases shot up and took off quickly, because they're following this pattern of it really takes about a week for exposure, and then you quickly spread it. So if people start getting exposed within 1 or 2 days, give it 1 or 2 weeks, and everybody's going to start being exposed. It can involve any mucous membrane. Again, our training in the West generally focuses on one of these, which is the pharyngeal and tonsillar characteristics, but it can hit the nose, it can be down into the larynx, it can be cutaneous. And then what happens long-term if you survive those initial phases is there are long-term complications, the most important ones and critical ones being the myocarditis and neuritis, which we will talk about. And then as we get more interested, the reason this is such a big issue is the case fatality rate is 5 to 10%. So you have a roughly 10% chance of dying if you get diphtheria. But if you are less than 5 or greater than 40, and I was kind of upset to understand that greater than 40, it counts as an advanced age in this case. But personal concern there. But you have up to a 20% case fatality rate. So if you're really young or really old being over the 40, you have a 20% chance of dying if you get diphtheria. So again, if you're not immunized, I strongly suggest you take care of that. So moving on. Looking at some of the characteristic manifestations of it, again, the most critical one that we really talk about, and the one that that we know about, and the one that is the one that causes most of the illnesses and deaths out there, is the pharyngeal and tonsillar one. It starts off fairly non-specific, so you don't really know what you're dealing with right away. Just the typical malaise, you have a sore throat, you don't feel like eating, you have a low-grade fever. So especially if you're a 4-year-old kid, you could have just about anything at this point, because this is how they all present with any illness. As a small child kind of has a sore throat and they don't want to eat, and they have a little bit of a fever and they don't feel good. So it isn't until about 2 to 3 days in they start to develop that characteristic pseudomembrane, that really thick, adherent mucoid stuff in the back of the throat. And then along with that, they start getting some marked submandibular and anterior cervical lymphadenopathy, which that and all the subsequent edema that goes along with it gets that bull neck characteristic that we read about and we hear about. If it progresses and gets worse, and often it does, they can go into shock, they can become stuporous, go into a coma, and then they can die within 6 to 10 days of manifestation, of initial presentation, if not earlier, for various reasons. So moving on to the next slide, I think I have pictures. Excuse me. So that is a pseudomembrane. So it's very, interesting, again, having never seen one, to have now seen them and how they develop. Usually it develops with a small few little exudates in the back of the tonsils, which makes you think, well, could this be exudative pharyngitis? Could it be strep throat? But very quickly it coalesces and forms this, it's hard to see in this picture, this gray, thick, edged appearance that you develop in the back of the throat that then coats all of the tonsils and the back of the pharynx and can move down into the larynx. On this one, you can see it's on the patient's right. You can see that kind of sail edge up on the upper right of it. That's that firm border. And so that becomes characteristic pseudomembrane, pathognomonic. Nothing else causes this. You see that, and you know you're dealing with diphtheria. Next slide. And here are the bull necks. So again, some patients with bull neck. The patient, on the left, on his left, you can see the swelling and the lymphadenopathy forming that bull neck, and the kid with the mask being pulled down. You can see that going all the way across underneath his neck, and from both sides, kind of started on the left and moves across. So you have this bull neck, kind of like a bullfrog, hence the name bull neck. I thought it was had to do with a cow, but apparently it's the bullfrog. Next slide. And again, another good shot of a bull neck, kind of taking up this small child's entire neck and giving him this gigantic, you can imagine how much edema is going on in that airway if that's coming down and cruising all the way across the front of his already very short and anterior, his short neck, and it's probably his very anterior airway moving into all of that edema. So the other manifestation that we actually did see while we were there, and that because all we learn about in the West is the pharyngeal, is that it also is cutaneous, and it can do anything. So it can form its own ulcer. So you can see the ulcer in that lower picture. That's a picture that I pulled off the internet, because we never had a picture like that. That's just the one that shows up in all of the posters and everywhere you look at it. But what we tended to see more was things like behind that kid's ear there, this scaly, looks almost like impetigo or a really bad eczematous rash, but that was actually diphtheria. So when you're dealing with diphtheria and then you start seeing rashes, you have to consider that you're dealing with cutaneous diphtheria. We know this one was diphtheria because we had the opportunity and the ability to culture it, and it did grow out as diphtheria. So now, as you can imagine, you have now all the little diphtheria bugs hanging out right on the skin, so it becomes incredibly contagious. It's not living in someone's airway waiting for them to breathe on you or cough on you. It's just right there out in the open looking for the next great place to live. So moving on. Another thing you need to consider, so we're going back into care in the refugee setting, is where are you? So you're in a refugee camp. So there are a lot of things that are going to affect your ability to practice medicine. And in our case, this was the ability to treat patients for diphtheria. And that's the front shot of the main gate into our clinic area that Samaritans first set up. You're in the refugee camp, so you're dependent upon the fact that you got to provide probably your own power and your water and your security, because, like, especially in this case, before Samaritans first built a clinic right there, that was a field. And then truly through God's provision, the field was provided to us, and then the workers showed up, and within a week they had it cleared and started erecting a facility out of bamboo. And then with help through the ability of those first on the ground to scrounge with the World Health Organization, we're able to get up the tents, which we will see in a second, and put them up. But you need to think about things when you're living here. How are these environmental issues maybe going to affect your ability to practice medicine? Because we're not in a nice, clean, sterile environment with power and water and electricity and air conditioning and fun things like that. Can you live there, or can you not live there? In our case, we were not allowed as expatriates to live down in the camp where this was. So, but you had to run 24-hour operations. So how are you going to rotate your staff, and how are you going to get them? How are you going to feed everybody, including your patients? How are you going to get all of these logistics taken care of that will impact your ability to care for people? What are you going to do for sanitation? And as things go on and on and on, this affects your ability to care for your patients. So you have to take those into effect beyond the just, I'm going to deliver medicine to people. If you're going to be in a refugee camp. Moving on to the next slide are some pictures, other pictures of the camp. So you can see there are some tents. So initially we were set up with tents. Again, as I said, borrowed from the World Health Organization. But then the great teams working there with the local laborers, many from the camps themselves, mostly all from the camps themselves, built these bamboo structures. You can see the one on the right going up. And I would name the people that were working on all this, but I don't want to, and especially all the folks that from Samaritans first that were running this, but I don't want to make the mistake of forgetting somebody. So forgive me for not naming anybody. Next slide are more, so you see more work going on. So throughout my stay there, and I was there through most of the month of January, got there the first week of January and left the first week of February, there was a constant construction going on as we were trying to treat and figure out how to care for all these patients. We were constantly building and improving the facility to make it, what I think was really a very high quality facility for this, considering where we were, which again was through God's provision and leading, to make an area that was not only safe for patients, but also healing in so many ways other than just their straight physical illnesses, which we will get to more later. So moving on. Now, what were we doing there? So again, when you come into these settings and you're working, in a humanitarian setting like this, especially in an area that's very austere, you have to have a clear reason for what you're doing. As was mentioned in the introduction, I spent 20 years in the Army, so we would usually call this our mission and our rules of engagement. In our purposes in Samaritans First, it's what is our mandate? Why are we there, and why are we allowed there? So, and that is going to dictate everything you do based off of how much stuff you bring, what kind of care you provide, how and when you're going to do it. And in our case, the mandate's going to be only diphtheria. This also has impact on your surrounding level. You have to consider the impact you're going to have on the surrounding level of care around there. Are you doing something that's going to interfere or isn't sustainable to everybody else? Excuse me. And how is it going to affect your ability or other people's abilities to do care down the road, not today, but tomorrow? You got to think about patients don't follow the rules. So if you say you're only taking care of diphtheria, but what happens when people with other illnesses show up? You're going to have a way to deal with them. For example, while I was there, we saw measles, we saw mumps, we saw rheumatic heart disease, we saw malnutrition, we saw asthma, and we saw many, many other diseases, but we were only treating diphtheria, and that's all we had in terms of equipment and medication to treat was diphtheria. So how do you treat things outside your mandate or your ability to take care of? And there are a lot of ethical issues that revolve around that as you go through the response. When you have someone in front of you with a disease you may or may not be able to treat, or maybe you are able to treat, but it's not within your mandate. So there are things you have to come to grips with. Again, our mandate was we were going to treat active disease. We are working to prevent complications and death, and we are assisting with controlling the outbreak, and it is all diphtheria. So the next slide. So one way you deal with all of this is that you have to know who the people are in your neighborhood. So these are the people in your neighborhood, the people that you meet when you're walking down the street each day. And we all need our friends. So these were only some of those that were around us doing things within the refugee camp of where we were. So everything was kind of running under the Ministry of Health of Bangladesh. So that's the one with the flag there written in Bengali. The World Health Organization was obviously heavily involved in organizing the international response. But you see, we were there, and then you have the UNHCR was there doing things. You have Red Cross, Red Crescent societies. You had MSF. You had teams from the UK. You had people from all over the world showing up and doing various different things and had different mandates. So Red Cross was running, for example, there was a Red Cross kind of just health clinic, all-purpose primary care health clinic right down the road from us. There was the MSF had a pediatric inpatient facilities. And other inpatient facilities. There are multiple other people taking care of diphtheria besides us at the time, including MSF and the UK teams. So you just had to know who was around and what their resources were and how do you get a hold of them, which helps you figure out that I can't take care of this problem that has just walked in my doorway, but I know who can, and I'll get you there. Or vice versa, as is our case study we're looking at, it goes around the other way. So moving on. Just going to go quickly through the slides if whoever has them out there, if you want to see them or pull them off later. This was our basic protocol. They walked in, we screened them, we said, yes, we think you might have diphtheria versus something else. Then we took a look at you, and yes, we're pretty sure you have diphtheria. Do you have a pseudomembrane or bullneck or something that looks really bad that we need to give you diphtheria antitoxin to, or do we just need to keep you around for 2 days to treat you with antibiotics so you'll no longer be contagious before we send you back home to your community somewhere in the camp as a hope to try and prevent you from spreading the disease. So next slide is the rest of the protocol. So moving on. What we could do, so back to our case. He has marked oxygen requirement now. He is stridulous and he is wheezing. He is pending respiratory failure at this point, and he has a worsening mental state. So what can we do? Next slide. So emergency interventions are always, if necessary. There's a couple things you do. First, you do supportive measures. So we get them hooked up to an IV. We get fluids into them. We get oxygen into them as best we can through a mask or other things. Always have to think about nutrition in general. Now, in this case, we got to think about, could we do a surgical airway? Because that is the mainstay of get someone who has diphtheria and their airway is closing off, either intubate or you do a cricothyroidotomy. In our case, we had thought about these things going into it, and the decision was made for various reasons that we weren't going to do a cricothyroidotomy, primarily because very few, and at the time when this child came up, none of us had ever done one before. Also the question is, after you do it, what are you going to do with the patient who now has a hole in their airway? And there are also many other ethical issues and concerns that we had to think about of how this would affect things. And the decision was made across the board generally by those taking care of folks with diphtheria that we weren't going to do the surgical airways, at least at that time. Next slide. So, but you do treat with antibiotics. So in general, it is highly sensitive to penicillins and macrolides. So the protocols called for erythro, azithro, or penicillin for PO. We went with azithromycin because it's the easiest to deliver, and it's what we were given by the World Health Organization. Parenteral, same things, penicillins and erythromycin. So we would give that parenterally if we had to. We also had parenteral azithromycin. Moving on. Excuse me. And we'll get back to our case, but in a little bit. But as I mentioned before, you have to worry about the complications and what's going to happen with diphtheria. And this is what drives why we give the antitoxin. Because not only is that causing the immediate stuff, it's going to cause the long-term issues. The most critical one being myocarditis. Abnormal heart rhythms usually happens 30 days after onset, but it can happen within days. And there were reports, especially from the other clinics, of people dying very soon after presentation. And when they died, it was often because of this bradycardic, tachycardic changes that occurred while they were being treated. And one suspicion is that could that be early myocarditis? Could also have been early reactions to diphtheria antitoxin, but more likely it was probably early myocarditis. And then we did have at least one case come in 30 days after they had been treated with abnormal rhythms. And that's it right there. And if you blow it up and count it out, this person now had a 3rd-degree heart block, which was, my guess would be, was caused by a myocarditis from diphtheria. Next page. You also get a neuritis 30 to 60 days later, the most common one being soft palate paralysis, because that's where the diphtheria and the toxin was. Can affect eyes, limbs, and even later down the line can affect your diaphragm. We did see at least one case of palatal neuritis also while we were there. But the mainstay of treatment to prevent the serious complications is diphtheria antitoxin, as we saw won the Nobel Prize in 1901. As I said, it comes from a horse. Those are the indications. You can see that the side effects are that it's really a nasty drug. Anaphylaxis, serum sickness is highly likely because it comes from a horse serum. And almost always when you start administering this, the patients become febrile, they become rigorous, they get tachypnic and tachycardic because of all of the reactions that are going on and the bad humors. And you have to be aware that that's going to happen when you give them the medication. And however, it's the lesser of evils. They give them the medication versus obviously letting them suffer with diphtheria. Next slide. So the procedure that we would go through, and it is kind of the recognized procedure. Informed consent. You do sensitivity training to see if they're sensitive or not, and if they are, you desensitize them. There's protocols for that. We would pre-medicate just like you would for other things with antipyretics, antihistamine, steroids, and then you give it really slowly. Next slide. The dose, you can look them up, but it's the dose for no matter what your age is. It doesn't matter if you're 5 years old or you're 50 years old. It's the same dose. It's all based off of how bad you look by presentation. And those were the protocols right there, depending on which presentation you had, from not so bad to really bad. So little dose to big dose in simple pediatrician terms. That is it being administered. That is the intent where we used it. Resource intensive because everyone needs to be monitored, ideally one-on-one throughout the course of the administration. To do every patient should have. Didn't always have it. A lot of things wasn't what we. I don't do what they do, and just in awe of how fantastic our nurses were and how they dealt and got through with these patients in the settings they were doing it. Next slide. It works, so we can move it to the next one once you get past this one. So it works pretty quickly. This is our patient we saw before with the pseudomembrane, and then you can see it kind of fading away as we go through time from the left to the right. And that happened over the course of about 24 to 48 hours. That pseudomembrane just disappeared and melted away. And people come in looking really sick and looking really miserable. They get treated with the antitoxin, and 2 days later, they were, much, much better and able to leave and go back to their home, and, just a remarkable transformation. Next slide. So I said one of our mandate was also to prevent disease. So it's 48 hours of antibiotics inside some facility. As an aside, once anybody comes into the facility, they have to wear a mask, and if they're in the areas that are considered unclean. And then we use universal and droplet precautions, especially if you are dealing with people who are really sick, such as those requiring antitoxin. I'll be very honest. We were not always really good about wearing all of the gowns and masks because as we all know, it's just difficult to do that, but we did our best. We also worked with the organizations out there who contact entries of antibiotics. And then, of course, the mainstay of treatment is always vaccination. Next one, and it's just kind of to go through certain things.
Dr. Doyle, we're missing your audio presentation. You started cutting out during your description of the DAT cave, and now that you're in the prevention measures, we started losing you again.
Okay, can you hear me now?
Yes, better.
Okay, so
thank you.
I talked about the DAT cave, and all I was saying, so the DAT cave probably missed the most important part, which was that that the DAT cave requires a lot of one-on-one nursing care, and if it wasn't for the nurses, we would never been able to never would have been able to do what we did. So I'm impressed with them. So whatever slide came after the DAT cave was the slide with the pictures of them getting better. So to quickly sum this up, is DAT gets you better very quickly. So you can see the pseudomembrane on the left, and as we move across to the right, that's how it faded on this patient. Within hours to a day or so, the pseudomembrane was resolved, and within 48 hours after treatment, they were this patient was much better, and generally they are, and there they go, and then they can walk away. So prevention measures. As I said, everyone comes into the camp and then they get admitted for 48 hours to make them no longer contagious and before they can go home. Once you come into the camp, you had to wear a mask. And if we were working with patients closely, we were supposed to be wearing masks and gowns, but we weren't always good at that because at times it's just really hard to wear the masks and the gowns. We all know that, all of us who do this thing called medicine. It's hard to do. And thank goodness we weren't dealing with something like Ebola where it was really critical. All of us were immunized, and so it wasn't as critical, but we could have been better. We also worked with contact tracing folks who are being run by various other organizations who would go out and figure out who all the contacts were to the known cases and start handing out 14 days of antibiotics to all of them to prevent them from getting sick or to try to prevent them from spreading it. And then, of course, the mainstay is always vaccination, and vaccine campaigns were starting in the camps as I left in the end of January, beginning of February. Now, next slide. So just a quick overview of kind of how the days went at the peak during my time. Could easily screen over 100 patients to see if we thought they had diphtheria or not. And these were just the ones that showed up that we thought required additional screening. Many more could have shown up at the gates who didn't have diphtheria-type symptoms at all and were referred somewhere else. Could admit up to 20 for isolation for 48 hours. We had 80 beds available, upwards of 80 beds available, so you could see we could fill up pretty quickly. You could be treating anywhere from 5 to 10 patients with DAT, and again, it could take 4 to 6 hours to treat each patient. We also worked with other, with some Rohingyas to go out into the camps looking for patients who might have diphtheria. I'm going to say that they saw hundreds of people. They would come back with their numbers of who they saw, and sometimes it was upwards of thousands of people. I'm not sure which is true, but they could have been close to thousands if you figure there's maybe upwards of 10 people living in every single home they go into. And then we would provide contact medications and information. Next slide. So in the end, what happens is these are our patients, and they come in sick and miserable and not feeling good, and we quite honestly cared for them and we loved on them, and we provided an environment that was nurturing and caring and supportive, and you can see the difference it makes. And really that's what it comes down to when you're taking care of patients, is what is the difference that you can make? And in our case specifically, how are we really showing them the love of Christ? And are we doing so while we treat their really bad disease and potentially do some painful and bad seemingly bad things to them, and we're making them live in our little facility for 2 days enclosed wearing masks. But are we showing them the love of Christ as we do so and conveying that to them, and what difference does it make and how do they respond? And then which just brings us back to the next slide, which again is, are we being the Good Samaritan? And are we demonstrating that as our namesake says? And how is, are we leaving them an impression? Because in this case, where we weren't allowed to openly proselytize to our patients because that was illegal, and it would have probably negatively impacted our ability to actually be there. But we could show them the love of Christ in everything we did and see if we had an impact on them, which I hope we were able to do. So as we close out, we're going to go back to our case. So our patient was unable to maintain his SATs at 90% with a positive pressure. So we ended up bagging this child as best we could. At one point, we tried to intubate him, and that was a failure in oxygenating him. So we just had to bag him as best we could. He has very little air movement. He loses consciousness. And so what diagnosis are we dealing with here? Could be diphtheria. But I'll be honest, in the end, we've kind of came to the conclusion, because we looked in his throat and he didn't have a pseudomembrane and he didn't have a lot of edema back in the back of his throat. He might have actually probably he had really bad asthma and was going into respiratory failure because of his asthma. The problem we only had the medicines to treat him for diphtheria, but that meant we had albuterol. That meant we had racemic epi. That meant we had steroids. It meant we had ketamine, and it meant we had mag sulfate. All of those which you use to treat really bad asthma. And but I'll be honest, didn't look like he was going to make it. So we had a lot of people praying, and God got involved on this one. And because here in the West, if I saw this kid in my hospital and I admitted him like this, he'd be intubated and treated for a week. This kid, after he got comatose, about 2 hours later, all of a sudden his airways popped right open. He became very easy to bag, and he woke up. And then the next slide is him 24 hours later. He is up and alert and smiling and playing with bubbles. And we started him on antibiotics for the diphtheria he was now exposed to, and sent him back to MSF, to their pediatric inpatient clinic, and he had a full recovery over the next week. All right, and that is the end of my presentation. So,
thank you, Dr. Doyle. I'd like to remind our viewers that if you have a question, please type it into the chat box, and then we can ask Dr. Doyle. In fact, we have one already, Dr. Doyle, from Alan Sawyer from Arizona. Hi, Alan. Alan says, excellent presentation. While treating with DAT, how long did the serum sickness symptoms last? And did you see any deaths secondary to serum sickness?
So we did not see any deaths secondary to serum sickness. While I was there, we had 2 deaths, and those were directly related to airway edema and closing completely off of the airway to the point where we could not intubate them. And as I said, we had made the decision not to do crikes. The serum sickness, just the general bad sickness of the fevers and everything else going on, lasted throughout the duration of giving the DAT. But we got very aggressive with pre-medicating and then providing medication as soon as they started coming up with any other breakthrough symptoms. So once we got them done with the DAT, they were usually fine from a serum sickness perspective.
Thank you. While we wait for any other questions to come forward, I have one for you, Dr. Doyle. Mm-hmm. If you can make only one recommendation to another health care provider who's preparing to deploy to a similar situation, what would that one recommendation be?
The one recommendation, if you're going to this sort of area, is, well, the one thing is trust your training, because you're going to rely on that, more than anything. But I would make sure you know what you're just getting, the living conditions of where you're going to get into and how you're going to deal with it, because the medicine is going to be the easiest thing you do in this sort of situation. The bigger thing is going through figuring out how to be adaptable and adjust to the situation you're in and making things work. And be willing to be creative and be willing to take risks that you would never have to take in a Western setting.
Thank you. I think that those points are well taken. To trust your training and to anticipate the biggest challenges to come from the living situations and the context rather than the actual medical situations. We have a comment from one of our support people here, Ashley, who says, love the Balto reference, such a great movie, and I never knew that that was the serum. I personally also appreciate your delight and love for those children that even comes through your presentation. So I appreciate that. Any last questions? Okay, I think you answered the other question I had, which was, what was the greatest challenge you faced? Or you sort of alluded to that. It might have been the actual situation of the camp. Do you have anything you'd like to elaborate on about that?
Yeah, I mean, really, the greatest challenge was the camps and adjusting and figuring out how to take care. You're working through those. You know, someone's really sick. You know what you need to do, but you don't necessarily have the ability to do that. And then, quite frankly, it's just the stress. In our case, we were working 12-hour shifts, 7 days a week, and then a 1-hour drive each day to and from, so 2 hours on the road to get to where we were. And that just cumulative stress builds up on you. And then, quite frankly, then our 2 deaths were 4-year-olds. And, one child dying is tough. 2 children dying is even harder. And you add that all together. So that would be the other thing to keep in mind through all of these sorts of things is be willing to be vulnerable. Be willing to rely on those around you because everybody's going through it. And today may be your bad day and you need help from somebody else. But another day may be their bad day and they need you to help them out.
Good point. I think that's an advantage we have as believers, even if we don't know each other before we land in that situation. We have the common bond as believers, and there's just something really healing about that as you go through that. So I think we'll go ahead and wrap things up today. We really want to thank you, Dr. Doyle, and to our viewers for joining us. And I'd like to remind you that CME credit is available for this session. The form and instructions are in your email, and we will be sending a follow-up email with a link to this recording. If you're not already on our email list, please go ahead and join the forum through the email you received at health.samaritanpurse.org, and you will be the first to know about upcoming events, which brings us to the next webinar, which will be Wednesday, October 10th, with Dr. Keir Thalander. Thank you so much. Have a great day.